Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm the Chief of Pediatric Cardiology. Thank you very much for joining us for the 302nd episode of Pediheart. I hope everybody enjoyed last week's episode on the topic of prediction of outcomes in tetralogy of Fallot. We spoke with Dr. Tal Geva of Boston Children's Hospital. For those of you interested in general pediatric cardiology as well as adult congenital cardiology, I'd recommend you take a listen to last week's episode 301. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move on to the world of interventional cardiology. The title of the work we'll be reviewing is Ductal Stenting in Low-Resource Environments. The first author of this work is Navaneetha Sasikumar, and the senior author is Raman Krishnakumar, and this work comes to us from the Amrita Institute of Medical Sciences in Cochin, Kerala, India. When we're done reviewing this paper, Dr. Sasikumar has graciously agreed to speak with us all the way from southern India. Therefore, let's get on to this paper and then a conversation with its first author. This week's work starts with a few comments about how there is a massive unmet burden of congenital heart disease in low and middle income countries, with infants and neonates particularly suffering from attrition due to the scarcity of centers able to manage such patients. And they note how infants with ductal-dependent pulmonary or systemic circulations are particularly vulnerable in this setting. This is because the health system does not always allow for quick and early diagnosis and referral to the more advanced centers, and they reference a work from the same center demonstrating that ductal-dependent lesion patients had the highest overall mortality, and they remind that this still remains the case despite government-supported pulse oximetry screening and organized referral networks sponsored by the government. And I'm sure many of you recall our conversation with Dr. Krishnakumar, who's the senior author of this catheterization paper, back in episode 186, 3 years ago in 2021. The authors review how the BTT shunt has been the traditional approach to patients who have ductal-dependent pulmonary circulation, but how the morbidity, mortality, and resource requirements of neonatally shunted patients are all very substantial. And they note how ductal stenting has become increasingly popular to replace BTT shunts in many infants, with some reports suggesting lower morbidity and mortality, but with higher reintervention rates. The authors explain how they started using ductal stenting rather than BTT shunts, and they wish to report their experience and thoughts about this change, and they specifically wish to address the following 5 concepts or questions. And these are namely, first, what are the advantages of stenting the duct versus a BTT shunt in a low-resource environment? 2, what steps are important to select the case and prepare for the case? 3, what hardware or technical innovations have enabled this approach in a low-resource environment? 4, what are the unique challenges in a low or middle-income environment to stenting ducts? And finally, 5, what can be done to improve outcomes beyond what's reported here today? And this is how the authors basically set up this article, and so let's review their step-by-step review of each of these 5 elements in the paper. So first up, what are the advantages of ductal stenting in a low-resource environment? First, ductal stenting can be associated with lower morbidity and shorter hospital ICU stays, and they remind how important rapid turnover is in a limited resource environment, and how this can potentially allow for caring for more children while also reducing an individual patient's exposure to risk for infection that comes with hospitalization. In their data set, the authors demonstrate that the procedure to discharge days were 7 in the past 10 years for stented patients, of which there were 193 patients, versus 12 days amongst the 73 shunted patients. Again, 7 days after a stenting and 12 after a shunt, and this difference was statistically different. In similar vein, the ICU stay was lower at 5 days for stented patients versus 9 days for the patients who had a shunt. The authors also explain or mention how works comparing ductal stenting to BTT shunt have not shown marked differences in acute mortality, which stands in the range of about 7 to 8%, but they do reference works suggesting that there is better survival to the next stage in patients who've had a ductal stent. They then point to the lower costs associated with a lower ICU stay, which they do not actually study in this work, but which they state is likely the case given what we know about days in the hospital and cost. The investigators then briefly discussed their experience of patients presenting substantially older than might be seen in the West, who have deep cyanosis, and they explained that ductal stenting is a relatively easy palliative approach that can buy time to improve a patient's candidacy for eventual definitive intervention, allowing a patient to be operated ultimately in a better physiologic state. And they mentioned that from 2011 to 2023, there were 43 infants over a year of age in which they used ductal stenting for this indication. Mortality was quite low, with only one death in this cohort of 77 older children presenting with deep cyanosis. And they mentioned how the one death they had was actually from reperfusion pulmonary injury. They then make special note of late-presenting detransposition intact septum patients who have detrained LVs, in which they stented the duct in 6 patients, with all 6 ultimately undergoing a successful arterial switch at a median interval of about 8 months from the ductal stent, and the authors report that no patients have had ventricular dysfunction so far. They then delve into what they view as particularly important in case selection and pre-procedural evaluation. They explain that in an environment of limited resources, quote, the need is even more to ensure that the procedure is meticulously planned and as far as possible all potential problems are anticipated. They speak of a procedural checklist including such things as demographics, important patient characteristics, and pre-procedural medication. They believe that a lot of time should be spent on reviewing the ductal images on echo to best understand the anatomy, and explain that in their experience they don't actually believe a CT is needed in every case if they feel that they understand the anatomy well on echo, and they mention that only 5 out of the 193 patients who had a ductal stent, or 2.6% of the cohort, actually required a CT scan. In regards to the echo, they state that the study should carefully assess the following features: the origin of the duct, the course of the duct, the number of turns that the duct takes, the insertion of the duct onto the PA, the presence or absence of branch pulmonary artery stenosis at the site of ductal insertion, and finally the size of the branch PAs and length of the main PA segment. They speak of planning the vascular axis, and in Figure 3 offer a few different drawing examples showing how understanding the relationship of the aortic end of the duct and the head and neck vessels could be critical in determining an optimal location to obtain vascular access and perform the case. They then speak about their management of prostaglandin around the time of the procedure and discuss infusing prostaglandin intermittently for 12 to 24 hours prior to the case, with the hope that this will result in some constriction of the duct, and they shoot for a minimally acceptable SAT of 75 to 85%, and explain that on the morning of the procedure they commonly turn the prostaglandin off unless the ductus is tortuous, which would not require turning off the prostaglandin, as there is typically more areas for opposition of the stent and the PDA in that setting. They then explain that ECMO is not feasible as a backup at their center, but having surgical backup is very important, and they always have that available for the rare case that is unsuccessful and goes south. And what sort of situations would be viewed by the team in India to not be a good candidate for stenting? Well, they list 3, and these are: first, when the PDA has completely closed and does not reopen with prostin. That seems fairly self-evident. Second, when there was bifurcation stenosis at the insertion site, potentially resulting in a PA isolation. And finally, when the duct had so many tortuous turns that there was concern that safe placement of the stent was not possible. Certainly, given the tortuosity that we see in many ducts, I'd be interested to hear Dr. Sasikumar's comments regarding just how much tortuosity is too much. Though technical details of ductal stenting are likely beyond the nature of this podcast, I would direct any interventional cardiologist listening to Table 3 of the work, in which they discuss things like CTO wires, guiding catheters, the use of radial introducer sheaths, microcatheters, and coronary stents, and review how most of these tools are actually stolen from our adult colleagues and their toolbox. The authors then review what the unique low-resource environment challenges for ductal stenting are. They speak first of low birth weight, and then they give some recommendations regarding ductal stent diameter and weight. First, they do not do this procedure at children who are less than 2 kilos. Between 2 and 2.5 kilos, they prefer 3 millimeter stent diameters, and between 2.5 and 3 kilos, they prefer a 3 millimeter diameter for a short duct that's less than 10 millimeters, or 3.5 if it's longer than 10 millimeters. For any newborn over 3 kilos, they prefer a 3.5 millimeter stent. The next aspect of working in a low-resource environment is the long-standing challenge of sepsis, and they highlight how nearly 19% of infants having stents had an elevated CRP post-procedure, and perhaps even more worrisome, 18% actually grew an organism following procedure, with 22% needing antibiotics after it. The last major low-resource specific challenge is that of follow-up in a system that does not have an organized health system with referral structure, which results in problems following the procedure for follow-up. And the authors explain that of the 193 ductal stent patients, follow-up was available in 150, with a median follow-up of 32.5 months. They explained that 18 patients required reintervention at about 104 days post-procedure, and 3 patients needed a BT shunt, with 2 immediately after ductal stenting due to in-stent thrombosis. And so what happened to the 118 patients who underwent surgery after ductal stenting? In other words, these are the patients who were successfully stented and then had surgery. Well, 67 were single ventricle patients who had a bidirectional Glenn, 7 had interim palliation such as a BTT shunt or collateral banding, 37 had a biventricular repair, and 7 underwent a 1.5 ventricle repair, and nearly 40% of all patients in this group needed some form of surgical pulmonary artery reconstruction. Importantly, there was no early or later mortality amongst the 118 patients who had surgery following ductal stenting. And for those interested, Figure 5 is a very nice flowchart showing exactly what happened to the 118 surgical patients who started their journeys in life with a ductal stent. Going forward, the authors speak about the importance of developing formal protocols for ductal stenting and how they are evaluating such a protocol that they have developed for this purpose, including standard pre-procedural planning and assessment, proper prostaglandin titration of dosing, anticoagulation, etc., etc. They make special note of the prostaglandin titration in patients who have pulmonary atresia with intact septum or critical pulmonary stenosis, in which the ductus tends to be more straight, and therefore the risk for stent embolization is higher. They also wonder if more dedicated equipment for this might make sense. In their conclusion, the authors state that more study is definitely needed on the benefits of this approach versus surgery, but to quote them, quote, "The lower morbidity, overall resource utilization, and treatment costs make it particularly attractive for low or middle income settings. The decision for ductal stenting, as well as the planning and execution, are best described as a series of judgment calls involving many assumptions and compromises based on the knowledge, experience, technical expertise, and availability of surgical backup and other resources, including quality of ICU care. For the same reasons, an expertise-based randomized controlled trial of ductal stenting versus BTT shunts, as suggested recently, may not be feasible or ethical anymore in low or middle income settings." Well, this is an interesting report from the team in Amrita Institute, showing that this approach of ductal stenting has really taken root and is clearly their approach of choice. I'm interested to understand how they use the echo to avoid cross-sectional imaging, and also how they determine who is not a candidate. And also I'm interested in the notion of adjusting prostaglandin to effect, whereby the authors seem to be suggesting that they can almost dial in the size of the ductus that they desire. Thus, at this point, I think we should move forward to our conversation with the work's first author. Navaneetha Sasikumar is Clinical Associate Professor at the Amrita Institute in Cochin, India, where she is also in charge of the Adult Congenital Heart Disease Clinic. She's also a highly skilled interventional cardiologist. Dr. Sasikumar received her MBBS from Tirumala Dewaswam Medical College in Kerala and completed her pediatric training at Barkatullah University, followed by cardiology training at Maharashtra University of Health Sciences in Bombay. Following this training, she completed advanced fellowships in interventional cardiology, followed by adult congenital interventional cardiology at the University of Toronto. It is a delight to have her join us all the way from India today. Welcome, Navani, to the podcast. All right, I'm here now with Dr. Navaneetha Sasikumar. Dr. Sasikumar, thank you very much for joining us this week on the podcast.
Thank you for this opportunity. It is very nice to be here.
Real pleasure to have you. Thank you very much. Dr. Sasikumar, in your work, you suggest that one of the reasons that your team might choose to not attempt a ductal stent would be if the duct had multiple tortuous turns. As you know, many ducts have a lot of tortuosity, so in your team's view, what's too much to consider attempts at stenting?
This is one of the key considerations during patient selection. We find it cumbersome to use any objective measure like the tortuosity index on a practical basis. However, we spend time meticulously imaging the duct by echocardiography for its entire anatomy, origin, course, insertion, number of turns, as well as the branch PAs. More than 2 turns or 360-degree turns are quite challenging. And I also want to say that when our surgical team is unable to accommodate a neonatal BTT shunt, we tend to take up more challenging cases in the lab.
I see. And why would it be that they would be unable to do a BTT shunt? Is it just OR time?
Yeah, so essentially, if it is a setting where we work with limited resources, we have limited ICU beds, and if they are already full with 3 or 4 neonates, and we know that many of these neonatal BTT shunts have a long ICU stay. Plus, if they do not have the resources to cover for that long ICU stay, then we will consider taking up a more challenging case in that setting.
I see. Okay. Well, thank you for that explanation. Very helpful. Dr. Sasikumar, when you're assessing the PDA and candidacy for ductal stenting, how do you decide if there is a risk for isolation of one PA and that it's too great to warrant intervention? Your work showed that about 40% of patients in whom you had actually stented and then had surgery after ductal stenting did need some sort of pulmonary artery plasty. But I'm wondering if you might be able to provide us with some clinical pearls or signs regarding who you might say, based on the echo or the CT, might not be a good candidate because you're concerned that there'll be isolation of the pulmonary artery after stenting the duct.
Yeah, so again, branch PA jailing is one of the major considerations in ductal stenting. For us, presence of significant bifurcation stenosis is a clear indication of a BTT shunt over a ductal stenting. In other situations, we would stent the duct and watch for jailing after the stent and intervene only if there is significant reduction in flow to one side, which would involve recrossing and dilatation and rarely stenting. So as to PA plasty, I would say that it is oftentimes necessary for the surgeon to remove the stent, and I would be reluctant to consider that as a marker of PA jailing or distortion per se from the stent.
I see. Okay. I mean, most single ventricle patients do need pulmonary artery plasty anyways, so I think that's a very good point you raise. In the work, you speak about meticulous prostaglandin titration in regards to preparing for the ductal stenting, and particularly in pulmonary effusion intact septum. Can you speak to us about what you mean by this? I was wondering if you felt that you could really titrate a ductal diameter to dose. Traditionally, the classic teaching is that the duct is sort of binary, either open or closing. Thus, I'm wondering, how do you know if you've titrated it properly before you go into the lab? Are there signs or symptoms that help inform this? Is it echo-based, saturation-based? How do you know it's primed and ready?
Yeah, that's a great question. This is something that we have learned from our own experience. Some degree of ductal constriction is desirable to hold the stent in place when we do the stenting. When the constriction is too tight, it would be challenging to cross and get a stent across. On the other end of the spectrum, we have had situations where after the ductal angiogram, we had to back out as the PDA was too large. So we have found that the previous night, particularly, intermittent stoppage and restarting of prostaglandin, rather than a titration, would help to constrict the duct to a significant extent. We do this based on echo as well as saturations, and we target around 75 to 85 to take the patient to the lab. If it is a very tortuous duct, we would not stop the prostaglandin in the morning, but otherwise we will stop it in the morning of the procedure.
I see. And when you're turning it on and off, Dr. Sasikumar, do you have like a frame of reference? Is it like 2 hours on and 2 hours off, or are you just turning it off until you see a sat that you like and then you turn it back on? How do you make that determination when it comes on and off?
I would say we do not have a written protocol for that, but then yes, as you said, like 1 or 2 hours off, and then we meticulously follow the saturation in the duct the previous night. And based on the saturation response and how the appearance changes on the echo, we may restart or continue to hold for a while.
I see. Okay, interesting. Thank you. Well, for those in the audience, it is late in the day in India, early in the day in New York. So I'm going to finish up our interview with one final question. Dr. Sasikumar, you've trained in interventional cardiology in the West at Toronto, and I'm wondering if you might be able to speak to us about the major differences that you encounter in some broad strokes when we speak about interventions in a low-resource environment, such as at your hospital presently, versus working at a quaternary Western location like Toronto's Sick Kids. What do you think we in the West could learn from your experience with ductal stenting in a limited resource environment?
Thank you for that question. There are indeed some major differences. The first is that our patients here are smaller. We see more of low birth weight babies. They're sicker as they present late, and they are more vulnerable to sepsis in our setting. The cath lab as such here is single plane and is shared with the adult colleagues. This has its own advantages and disadvantages, the sharing. And third, we have limited access to hardware. Fourth, the budget available for management is limited. So all of these necessitate that we sort of continuously adapt and innovate in the cath lab to account for all these. And as to the second part of the question, regarding what we may offer to the West from our experience, one thing is that a vast majority of the babies do not need advanced imaging, and we make our plans based on the echocardiography mostly. And the second that I would say with regard to ductal stenting is that a lot can be learned by working in partnership with the adult colleagues. The hardware, the techniques, most of it is adapted from the adult colleagues. So having them around and working in close partnership with them has been very helpful for us.
I see. Well, all great pearls. I'm happy to say that at my own institution, we work directly in the middle of a very large and busy adult cath lab, and certainly that has been our experience as well, that it provides a lot of extra help that can be very helpful in these types of situations. Well, Dr. Sasikumar, I can't thank you enough for joining us this week on the podcast. Of course, you and I off-air have discussed that you work with one of my very dearest friends, Raman Krishna Kumar, so please send him my regards. And thank you so much for taking time out of your very busy schedule to speak with us this week on the podcast.
Sure, I'll convey. And thank you so much for the opportunity.
Thank you. Well, I think you'll all agree that Dr. Sasikumar's comments really helped clarify her paper and work, and I found her comments on how they manage the prostaglandin to be novel and interesting, and certainly something that may warrant further study. I found also her comments about what we in the West can learn from her experience to be quite valuable, and certainly the notion that the CT scan is perhaps not as necessary as has been suggested by other authors to be something that again likely warrants formal study. I'd like to thank her once more for meeting with us very late in the day after a long day at work in India to discuss her work. It was a great pleasure. To conclude this episode of Pediheart Pediatric Cardiology Today, we hear a snippet of a very special occasion in the world of opera. In the late 1980s, the magnificent tenor Jose Carreras was diagnosed with ALL and underwent a bone marrow transplant in Seattle, Washington. At that time, his odds of survival were estimated near to 10%, but he did survive and thrived. And since that recovery, now nearly 40 years ago, he has dedicated as many as 20 concerts a year to cancer research and has truly given back, recognizing the important and life-saving role medicine has played in his own life. Today we hear him in one of his comeback recitals from the late 1980s, shortly after he had just triumphed over cancer, singing the Paolo Tosti song, Non t'amo più. Thank you for joining me this week, and thanks so much to our guest. I hope all have a good week ahead.
Ricordi ancora il dì che ci incontrammo, le tue promesse le ricordi ancora. Folle d'amore io ti seguì, ci amammo, e a accanto a te sognai folle d'amor. Sognai felice di carezze e baci, una catena di leguante in ciel, ma le parole tue furon mendaci, perché l'anima tua fatta e diger. Te ne ricordi ancora? Te ne ricordi Or la mia fede, il desiderio immenso, il mio sogno d'amor, non sei più tu. I tuoi baci non cerco, a te non penso. Sogno un altro ideal, non t'amo più. Non t'amo più. Nei cari giorni che passammo insieme, io cosparsi di fiori il tuo sentier. Tu foste del mio cor l'unica speme, tu della mente l'unico pensier. Tu m'hai visto pregare, impallidire, piangere, tu m'hai visto innalti a te, io sol per appagare un tuo desire. Avrei dato il mio sangue e la mia fede. Te ne ricordi ancora? Te ne ricordi ancora? Or la mia fede, il desiderio immenso, il mio sogno d'amor, non sei più tu. I tuoi baci non cerco,